Assalamu alaikum and good evening to you all. Welcome to the sixth episode of Health Talk. Health Talk is a health educational program organized by SCP Bangladesh chapter and supported by Bangladesh Society of Medicine. I am Dr. Prince Kawser. I shall be your host tonight. First, let me inform you that today's episode is going to be very interesting and informative as well because today we are going to learn medicine in a very fun way. So don't miss any part of today's program and invite your doctor friends or colleagues to join with you as well. Just like previous episodes, today we brought someone very special as a speaker with us. The speaker of today's program is Professor Muhammad Titu Miah sir. He is a principal and professor of medicine, Mugda Medical College, and former Secretary General of Bangladesh Society of Medicine. He will be discussing on pictorials in medicine, which is, we all know, a very interesting topic. As the chairperson, we have someone who is considered as one of the best physicians of our country, our very own current governor of SCP Bangladesh chapter, Dr. H.M. Nazmul Ahsan sir. He is the professor of medicine, Popular Medical College. We also have Professor Dr. Julhash Uddin sir with us as the chief guest. He is the professor and head of the Department of Medicine, Marks Medical College. Today's program will be moderated by our very own Dr. Ashim Chakraborti sir. He is the assistant professor of medicine, Sir Solimullah Medical College. During the live session, you can ask topic-related questions in the comment section. We shall try to answer them on the question and answer session right after the presentation. So without doing any further delay, let me hand over the session to Dr. Ashim Chakraborti sir to moderate today's program. Dr. Ashim Chakraborti sir.
Thank you, Dr. Prince Kawser. You have been already introduced to the speaker and as well as our honorable chairperson and chief guest. So with no more delay, we should start because a lot of students are waiting basically to learn and to now know about from Professor Dr. Titu Miah sir, who is Professor of Medicine and also the Principal of Mugda Medical College, and sir is immediate past Secretary General of Bangladesh Society of Medicine. May I request Professor Titu Miah sir to please start his topics, please, with the permission of Chairperson, sir.
Thank you, Ashim and Prince, for inviting me for my presentation. And my heartfelt thanks and gratitude to the organizers, especially the SCP Bangladesh chapter and Bangladesh Society of Medicine, jointly organizing the session as pictorial aspects of OSPI. And today's chairperson, honorable chairperson, who is my mentor, and he is also the governor of the Bangladesh chapter SCP. And another my mentor as well as my honorable teacher, and who is my whom I like very much and respect very much, the Julhash sir, and who are there as a chief guest. And it is my pleasure to find them in this session. So I'm starting my presentation. So pictorial part in medicine is definitely one of the important things because it gives some impressions to the learners as well as the trainees and also the physicians and the doctors about the certain diseases, and it almost it is near to the life of near life patients, like the life patients. So that we can imagine the total scenario, total disease process, the investigation procedures. So it will be definitely helpful for our trainees if we can discuss some aspects of the pictorials, in especially the which is usually encountered in the OSPI and other parts of the exam. So am I visible? Ashim, am I visible?
Sir, yes, sir, you are.
Are the slides are visible?
Yes, sir. Yes, sir. Those are clearly visible.
Okay. So am I audible?
Yes, sir.
Okay. So let's look at the pictures. This is the 67 years old male presented with dry cough and hoarseness of voice for 1 month, who is a known case of the post-tick arthritis, as well as he is an hypertensive patient. He is a smoker, and he was under my treatment. Very recently, he has developed hoarseness of voice, and after examinations of the patients, I have submitted him for to go for the laryngoscope, and this is the findings in the laryngoscope. You see, there is a nodule in the vocal cord, and the possibilities definitely we can think about the simple polyp, vocal cord polyp, but the polyp is a rather smoother one. Here there are some projections, so it might be in our country probabilities of the tuberculosis also there. In the vocal cord, which can happen in case of miliary tuberculosis and others, or isolated tuberculosis maybe in the vocal cord. Or it can be a metastatic mass from the bronchogenic carcinoma and or others tumor also. Or it could be the other masses or soft tissue growth from the vocal cord. So let's see what is happening. So we can describe the findings in a manner. There is a nodular swelling with some projections in the medial aspects. And then we can think of the possibilities. And we can also think about the further investigations. Definitely X-ray chase is the commonest investigations. And differentials I have mentioned. And we can go for the blood counts also. If the ESR is high and the blood counts are in maybe normal, or there are rare possibilities of the leukemic infiltration in the vocal cords is sometimes the rare possibilities. So mostly the ESR can give a clue whether it is a tuberculosis or any malignancy, metastatic lesions, etc. So his blood counts in this patient, it was almost normal. And finally, the biopsy was taken, and the patients were submitted for operative procedures of the nodule, and he had been operated. And you see the histopathology reveals the amyloidosis with plasma cell infiltrations. And why they have called the amyloidosis? It is from the eosinophilic depositions and the reports has been confirmed from the two pathology lab, histopathology lab. So this is a rare happening in these patients. But in exam, we should not say at the first diagnosis the amyloidosis, which is a very rare happening in this vocal cord. But we can think of what I have mentioned, the polyp, the tuberculosis, the metastatic depositions, and other remote possibilities. The amyloidosis is a very rare happening. So if it is really amyloidosis, what could be the next investigations we can go for? We can go for the underlying causes. We should take the histories and evaluate the patient, further evaluations for the underlying causes of the amyloidosis, which could be the multiple myeloma, rheumatoid arthritis, or others, immunological disorders, which may be associated with amyloidosis. The secondary cause of the amyloidosis are those. And also the primary amyloidosis may be there. And regarding the management of amyloidosis, as it is a local nodule, there is no other systemic manifestations. Clinically, what I have evaluated in the patients, and there should not be any systemic treatment. Otherwise, in case of systemic amyloidosis, we used to treat with after evaluation of the patients, especially the primary amyloidosis, we can go for some chemotherapeutic agents like the melphalan, like the mycophenolate mofetil, like cyclophosphamide, cyclosporine, etc. And sometimes the biological agents could be used rarely in case of amyloidosis. So this is another picture of a man. Just look at the pictures, how we can describe this. This is rather to somewhat the ulcerated, irregular margin, lesions over the shin. So what could be the possibilities? So this is could happen in case of, in our country, you can think of is it tuberculosis, is it like the cutaneous, which is not common in our country, but in patients with Middle East and other parts, cutaneous leishmaniasis or deep fungal infections could happen in these situations. And is it anything else? Sometimes post-traumatic unhealthy lesions or granulation tissue infected granulations may happen in case of post-traumatic where it is not nourished or taken care properly. So what exactly it is? Actually, there are some other conditions where we can think of the lymphoma. The cutaneous manifestations of the lymphoma may happen like this. So this is another lesions, which is the papilla rather. In this also another variety of the lesions in case of cutaneous manifestations of the lymphoma. This is especially the non-Hodgkin's lymphoma T-cell variety, and this is the extranodal manifestations. This could be another like the patch-like lesions. This is also another variety, but the differentials of the psoriasis and other skin diseases can happen in these cases or can take into account in these cases. But we should also think about what is mycosis fungoides and Sézary syndrome. I mentioned this is the extranodal manifestations of the lymphoma involving the skin. But what is the difference between the Sézary syndrome and mycosis fungoides? We all know, because mycosis fungoides means the only cutaneous involvement. In case of Sézary syndrome, cutaneous involvement as well as the blood infiltration. I mean the leukemic manifestations of the lymphoma. So there are certain questions, maybe how can you going for the next investigations? What is the importance of these cutaneous manifestations in the prognosis of this Sézary syndrome? So this is another slide which is just cutaneous manifestations of the lymphoma. It could happen in case of our tuberculosis, deep fungal infections. Again, we can think of sometimes leprosy or even other chronic infections sometimes may be associated with histoplasmosis. Also is a good possibility in this slide. But we should keep in mind the cutaneous manifestations of the lymphoma. So this is the histological pictures of the mycosis fungoides, the infiltration, the lymphoma-like infiltrations, monotonous cells. Histopathologically, it is found in case of histopathology taken from the skin. So what are the further investigations or for the further management? There might be questions. How could we going for the further management? Definitely in the staging of the diseases, and definitely management depends on the staging and other involvement of the other parts of the body. And does it contribute in the prognosis? Yes. The aggressive mycosis fungoides or the Sézary syndrome itself is a leukemic infiltration, is an aggressive diseases. So it can sometimes contribute in the prognosis, and the aggressive treatment in case of Sézary syndrome is essential for the better outcome. So this is about the mycosis fungoides. This can we should keep in mind that any cutaneous lesions which look like the tuberculosis of the skin and the other deep fungal infections, we should also keep in mind the lymphoma. So this is a common, the ophthalmologic findings, fundoscopic findings, the fundus. It commonly happens, and there are different findings. The exudates are there, vascular proliferations, dot hemorrhage. The fundus is almost normal. So this could happen. The hemorrhage is usually the dot and blot, not the flame shaped. So hypertension is not there. It is not a hypertensive retinopathy. So the typical hard exudates is off, and the dot blotch hemorrhage and to some extent proliferations of the vessels is definitely, we know, the retinopathy, diabetic retinopathy, and neovascularizations also there. So the questions of the previous slide happens by giving these slides, we can also interactive oral sessions may be started with asking some questions, management of the patients, and other investigations, and certain other questions also. So this is a very rare happening nowadays. This could rarely happen in case of fundus. Look like the eye, I mean the bull's eye. Hyperpigmentations followed by hypopigmentations and hyperemia. So this is called the bull's eye maculopathy, which can happen in case of chloroquine intake or hydroxychloroquine. Patients with rheumatoid arthritis or SLE sometimes because these patients are taking the hydroxychloroquine and chloroquine for longer durations. So these patients should be evaluated routinely even before starting the treatment, and also after giving the treatment, routinely 6 months interval, the patient submitted for the investigations for the the followed up for the involvement of the retina as a side effect of the hydroxychloroquine. Here, what the other questions can be? This can be a patients having look like these sorts of manifestations in the fundus retina. What are the other side effects may endanger the patients due to the hydroxychloroquine? Usually, conventionally, there is no endangerment of the hydroxychloroquine. But during these COVID situations, we have come across to learn about the malignant arrhythmias happens with the torsid depointes and other things due to the prolonged QT interval in case of, especially due to the side effects of the using of the chloroquine. So sometimes hydroxychloroquine on the background of the hypokalemia and other things may precipitate the malignant arrhythmia and may endanger the life of the patients. And we can also ask, what are the clinical situations we encounter to treat the patients with the hydroxychloroquine? And other questions may be raised accordingly. So just looking at the fundus, giving the fundus, or looking at the fundus, the examiner can ask many questions in case of interactive oral sessions, or in the the OSPI stations. What are the other investigations we can go for, or what are the histories we should take from the patients, or what are the clinical conditions I have mentioned where we can treat the patients with hydroxychloroquine. So this is the fundoscopic findings of one of my patients who were obese and apparently healthy, definitely, and there is no other pathology. She was hypertensive and with headache. And just when I have examined one eye, it was healthy. And on the other eyes, this was the typical findings I have found in fundoscopic examinations. You look, the huge different shapes of hemorrhages, and especially the superficial hemorrhages involving the whole of the fundus. And there is a papilledema, and other vessels is not very much visible. So what might be the underlying cause? Definitely the looking of the, because there is no other exudates or other things, it could not be due to the hypertensive retinopathy. Because the hemorrhages are huge, just like riot-like hemorrhage, we can say. So the good possibilities, because in case of hypertensive hemorrhages, usually it is not, papilledema, usually it is not unilateral, rather bilateral. So when we find the unilateral findings with these sorts of hemorrhage, we should think of the retinal hemorrhage, retinal vein thrombosis. And the patient apparently was healthy. So it could, next questions may happen, so what are the underlying causes of these sorts of findings in the fundus? So venous thrombosis, the precipitating factor for venous thrombosis are the conditions. Usually the hypercoagulable states or hyperviscosity syndrome happens with different situations, so like the CML or myeloproliferative disorders, like the antiphospholipid antibody syndromes. So there are many things where there is a hyperviscosity syndrome or hypercoagulable state, which could happen in case of with retinal vein thrombosis. And what are the other investigations we can perform? This could be asked in the question, in the Viva, even in the interactive oral sessions, or also in the OSPI session. What are the other investigations we can perform? Or what are the histories should be taken from the patients? This could be a question. In these patients, apparently the patients was good, just hypertensive. There is no other hematological manifestations, or we are not finding anything, any pathological conditions which may cause the hyperviscosity syndrome. Just after taking the history, she was taking the oral pill. So this is sometimes drug history, and taking the history about the oral pill may be associated with the venous thrombosis, and exactly what was happening with these patients. So history and clinical examinations subsequently will be able to find out to localize the cause of the retinal vein thrombosis, and subsequent investigations what we can do. Sometimes we can go for the other searching of the deep venous thrombosis. In case of brain, we can go for the MRV or the any other evidence of the deep venous thrombosis in the lower limbs and other parts of the body. This could be searched according to the clinical situations. So look at this gentleman. He is presenting with rather exophthalmic appearance, and especially on the left side. So what are the possibilities? Definitely, we can think of thyroid disorder, but thyroid disorder usually bilateral involvement. When we are thinking about the unilateral involvement, we should think of some other possibilities. I mean, anything involving the retroorbital space or infiltrating the retroorbital space, or any vascular phenomena, arteriovenous malformations. In this case, it will be pulsatile. But when exophthalmos non-pulsatile, we should think about the retroorbital depositions. And this gentleman was associated with, so far I can recollect, his blood pictures reveals the ESR was high with leukemic, there are probably lymphoblastic leukemia was associated in his conduct. Leukemic infiltrations, and very rarely lymphoma may infiltrate the retroorbital spaces, and very rarely other infiltrated diseases may be associated with these sorts of unilateral exophthalmos. So look at this funduses. There are some exudates not typical of the soft exudate, not typical of the hard exudate, but there is something different, which can happen rarely in certain situations. And this is depending on if we find these sorts of findings in fundoscopic examinations, then in exam there is a question: what are the history will take from these patients to target the etiology, to find the etiology of the patient. So where this can happen in case of certain and tuberculosis in our patients, the tubercle, or sometimes these sorts of findings are associated with the SLE or any other vasculitis, sometimes may be associated with this. So we should search from the history, we should search about the tuberculosis, whether the patient has got the tuberculosis, or whether the patients have the arthralgia, arthritis, or evidence of the vasculitis or SLE. This could be taken, and subsequently there might be some questions: what are the next plan of investigations you will go to find out the underlying cause of these patients? So I've mentioned about the tuberculosis. This is the choroid tubercle, and this is another one. So there are the conjunctivitis. Is the usual conjunctivitis, but here as we are in the tuberculosis, sometimes the tubercular conjunctivitis, involving the tuberculosis involving the conjunctiva, what is called the flictanular conjunctivitis. Sometimes we should think about from the pictures. If we look at these pictures on the left, picture A, the commonest site for the basal cell carcinoma, but histopathology reveals there is no evidence of the basal cell carcinoma. Same on the B pictures also. But this could happen because in our country, especially in this Southeast Asia, patients having these sorts of cutaneous lesions, always we should think about the tuberculosis or the lupus vulgaris. So this was the case of the lupus vulgaris, and subsequent questions like the previous slide from the history. We should take the history, and we can ask for the certain next plan of investigations. Definitely, chest X-ray is a very cheap and very, the essential investigations in all these patients. And we should carefully examine the patients for the disseminations of the tuberculosis in other parts of the body. And subsequently, we should investigate for the sputum and other things according to the involvement of the patient. And also the gene expert could be done in case of from these slides, or from the, if there is sputum or any other lesions is there, we can go for the to find out the AFB from these lesions. So this is a simple fundoscopic findings. Here the vessels are rather normal, macula is intact, just the cup is lost, the fundus is full rather, and the disc is full and a bit hyperemic. So early part of the, it could be due to the early papilledema or papillitis. So these are the very common things, and we can differentiate papillitis and papilledema. And subsequently, what are the underlying conditions can happen, and what are the other history should be taken to find out the cause of this early papilledema history, what are the clinical examinations, and other investigations could be done. These are the questions maybe we can encounter. So here the fundus on in the pictures, the fundus is rather pale and certain vessels are lost. And I found one patient like this, and there is a cherry red spot, because when the retinal circulations, retinal artery is occluded, there is pale looking of the fundus, and also the certain vessels, certain branches of the retinal artery is already occluded, and sometimes it looks like milky white. And the cherry red spot means the choroidal circulations is not due to the retinal artery. That's why the circulations become very much prominent and looks like the cherry red spot in the fovea centralis. And this is a case probably retinal artery thrombosis. And how this patient, and the questions may be how these patients may present it to us. Sometimes the blooding of visions, acute onset of the blooding of visions, or acute blindness may happen in this patient. And the questions may be what are the history will take to find out the etiology. The etiology of the retinal artery thrombosis or blockage of the retinal artery or occlusion of the retinal artery depends on the age of the patients and the clinical setup of the patients. If it is an elderly patient having the chronic headache or unilateral temporal headache, subsequently we find these sorts of retinal artery occlusions, we should think of the vasculitis like the giant cell arteritis. But in a young patients having the history of rheumatic fever, having these sorts of blindness, we should think of the valvular involvement leading to the low-grade fever, whether the patient has got the history of low-grade fever. If the patient has got the splenomegaly and the patient has the clubbing, we should think of valvular lesions with infective endocarditis. And there might be other thromboembolic phenomena may be associated with these sorts of occlusions of the the retinal artery occlusion. So history and examinations always demands to find out the underlying cause and to go for the underlying causes. And subsequent investigations, depending on the clinical findings and history, will guide us what or the other investigations should be done. This is this lady was a known case of rheumatoid arthritis, was presented to me for she was irregular in having the disease modifying agents, and after many months she has visited my in my chamber, and she was complaining about the redness of the eyes. And this is a patient on the background of the rheumatoid arthritis, is usually due to the scleritis or episcleritis. And these are the findings. And there might be a questions, what are the underlying cause other than rheumatoid arthritis, if any, or how are you going to investigate further? Does it contribute in the disease activity? There might be some questions. And if there is recurrence of this also episcleritis or scleritis, what are the treatment plan? These are the questions may be asked in the interactive oral sessions or even in the OSPE examinations. And the same patients he has developed also the scleromalacia when asked the patients to look downwards and elevated the eyelids. So scleromalacia is an advanced manifestations of the extra articular manifestations of the rheumatoid arthritis. So in this setup, usually the disease is very active and very much aggressive, and the urgent starting of the treatment with the steroids and other disease-modifying agents, and if necessary, the JAK2 inhibitors or biological agents could be started if the patient's manifestations or disease state demands. So this is usually commonly encountered in case of younger boys or girls or any patients, especially maybe due to the drug reactions or as a part of the infections like the staphylococcal skeletal skin syndrome. So questions maybe happens with the how history again what are the history we should take, how can we manage these cases if it is due to the staphylococcal skeletal skin syndrome, what are the differentiatings between the erythema multiforme or the drug reactions and staphylococcal. Definitely history and certain examinations and investigations will help us to differentiate. These patients, just look at this. This is the knee and thigh, the lower limbs. Looking at the patients, their vessels are engorged. And definitely, we commonly get these sorts of pictures in case of engorged vein or varicose veins. But interestingly, the veins were not very. These are the veins definitely engorged, but the patients was complaining since his childhood this happening, so which is unusual. And the other limb was absolutely good. And while I was palpating these patients, I was feeling the thrill. And when I was putting the stetho, there is a buoy over this. So this patient has got the arteriovenous connections with this sorts of swelling of the limbs. But apparently, just looking at the limb, what are the differentials? One is the venous varicosity. Second possibility is there any growth with high vascularity, like the growth involving the lower part of the femur. Could be the osteosarcoma or other malignancy, because it extends up to the thigh even. So these are the differentials. But interestingly, while I have found this, I have sent the patients for a Doppler study, and just I have done an X-ray. The X-ray is interesting. The best you look at the pictures, the posterior aspect of the lower end of the femur, there is some groups, probably due to the engorged vessels, and there is another circular hole over the upper part of the tibia. So this is due to the very much engorged artery, due to the arteriovenous communication. So this is a very rare thing, but there might be some pictures. We can ask for what are the differentials, what are the next plan of investigations for the varicosity, and to find out the underlying cause of this source of swelling. And if it is a varicose vein with the difficulties, there is no improvement with the conservative treatments, what should be the subsequent management? This could be asked. Surgery could be done, or radiofrequency ablations, which is usually done in our country also, if it is the varicosity. So This is another picture, just certain lesions, patchy lesions with some vesicles, some are crusted lesions involving the right side of the face and also the auricle, the ear, right ear, and to some extent into the upper part of the neck, over the sternocleidomastoid. So what are the differentials? Is it any infective process? Yes, this could happen in case of any viral infections or cutaneous staphylococcal infections or any other infections can happen in these patients. Exactly when we are finding unilateral distributions not crossing the midline, we should always suspect the possibility of the virus, herpes virus, especially the herpes zoster, and she was suffering from the herpes zoster. And what are the, if it is herpes zoster, the questions might be what are the things should know from the history. Definitely whether she has got any immunocompromised situations, whether she is diabetic, whether she is suffering from leukemia, lymphoma, or any other drugs she is taking like the steroid for the longer durations, or any chemotherapeutic agents are taking. These should be asked to the patients, and subsequently the patient should be examined also to find out any clinical situation associated with the immunocompromised associated with immunocompromisations. The same thing in these patients, it does not cross the midline. So this is a finger of an 55 years old lady suffering from the diabetes mellitus and hypertensive, and she was with CKD, presented with these sorts of fingers, sudden development of swelling of these fingers. I was thinking about because when there is a sudden onset of monoarthritis or sudden onset of acute arthritis, we should think of the possibilities, especially in medicine, especially gout, whether because the patient was CKD, but uric acid was normal, everything was fine. But what are the other possibilities? Because this was the first time she was encountered this. That's why we should think of always the acute gout. But sometimes if we don't know whether the patient is with CKD or diabetes, CKD or other causes of the hyperuricemia, sometimes the palindromic rheumatoid arthritis may present like this, or any other infective arthritis. Sometimes we associate with the acute monoarthritis. And questions may be asked whether the investigations you can go for the, investigations for the uric acid, CBC, and if possible, aspiration from the joint and submit it for cultures and other things, and also for the crystals. And also the patients could be investigated for the inflammatory arthritis like the RA, NTCCV, and other things. So what are the possibilities? Because the patient has gotten ulcers. So any ulcerative lesions, could it be infective? Could it be due to vascular cause or anything else? But sometimes, if we can remember, sometimes the cobra bite may be associated with these sorts of ulcer, prolonged ulceration. Of course, in case of acute setup, there might be discharge and other things. So what are the possibilities of these finger ulcers? Definitely trauma, tuberculosis, malignancy, histoplasmosis. As I have mentioned, the possibilities of the sometimes cobra bite, we should think of snake bite also. So what are the differentials and what are the next examinations and investigations you can do just looking at the fingers? There are some palpable lesions over the palm and in the fingers, discrete rather. Whether we should ask also about whether it is painful or not. So these are the lesions which may be associated with vasculitic lesions, inflammatory conditions, and because as it is palpable, most likely vascular cause or primary cutaneous lesions. But in our setup, we should also think of that, is it associated with the drug reactions And very rarely, viral infections may be associated with these sorts of palpable lesions. And of course, we have mentioned ITP. Here, I'm saying the infective endocarditis. In infective endocarditis, such a florid lesion is unusual, very, very rare. But vasculitis can happen with these sorts of palpable lesions. But in case of ITP, it is never palpable. So ITP is unlikely in this setup. Here the bilateral lesions involving the fingers, and there are some gangrenous lesions also in right hand, middle finger, and impending gangrene in other parts. So what are the possibilities? Definitely the hypercoagulable states or lesions involving the blood vessels, or any the atherosclerotic changes for longer durations, or any drugs, and very rarely the frostbite. And these are the things which can happen with these sorts of gangrenous-like manifestations, or involving the fingers, impending gangrene. So here the questions may be, what are the clinical examinations will perform to the patients for the underlying conditions, or what are the further history will take, or what are the history will take from the patients to find out the underlying cause. And again, we can be asked, what are the investigations we should perform. This gentle lady has got admitted into Dhaka Medical College while I was working in Dhaka Medical College, and she has attended in the rheumatology department, rheumatology clinic, with arthralgia and body ache and the back pain, but there is no evidence of the arthritis, just only arthralgia. And it's also lesions, multiple ulcers, and sometimes some bolus lesions were there. And ultimately, we have tried to find out whether the patient has got any arthritis causing this, but we have failed to localize whether the patient has got find out the rheumatoid arthritis or any seronegative arthritis. Rather, the patient was undetermined arthritis or connective tissue diseases was there. We have also looked for the evidence of the multiple myeloma and other things, and we have taken the history adequately. Any drugs or any immunocompromised situations were there. Finally, just looking at the ulcer, we have submitted the, finally when we failed to go for the another patients or similar ulcers, when we have failed to find out the underlying cause from the investigations, finally we have submitted the patients for the histopathological examinations. And both these patients were found out to be the pyoderma gangrenosum. So once it is pyoderma gangrenosum, then the questions may be, in the exam, there might be describe the ulcer, what are the possibilities, differentials. There are some ulcers or cutaneous lesions, these sorts of manifestations. Again, it could happen in case of vascular cause or as a part of the tuberculosis, deep fungal infections. And if it is ulcers are there, we should also think of the pyoderma gangrenosum one. And if the pyoderma gangrenosum, then the questions might be, what might be the underlying causes? What are the history will take from the patients to reach to find out the underlying cause? What are the further investigations you should perform to find out the cause of the pyoderma gangrenosum? Or there might be questions, how are you going to treat a case of pyoderma gangrenosum? Definitely the regular surgical dressing and other things, plus the treatment of the underlying cause, if any. Or if there is no underlying cause of the pyoderma gangrenosum, we know if it is due to the rheumatoid arthritis, SLE, it may be secondary to the multiple myeloma, or HIV, or any other immunocompromised situations. But if the underlying cause is there, we should treat the underlying cause, and also we should go for the treatment of the dressing and other things for the ulcers. But if there is no cause, the treatment of the pyoderma gangrenosum may happen with the steroid, high dose of steroid, and sometimes even the biological agents may be helpful in these patients. Just look at the arm of this gentleman. He is rather looks cachectic and was just presented to us with swelling of the upper arm. And there might be questions, how will you describe the finding? Please describe the findings in this gentleman in the upper arm. So there are multiple hemorrhagic spotted, the subcutaneous bleeding manifestations of different size shapes. So there is bruising of the upper arm. So what are the underlying causes? Definitely in elderly persons, is it due to trauma or any underlying hematological disorders, maybe associated with the bleeding manifestations, or the drugs, certain drugs may be associated with the bleeding manifestations, like whether the patient is having the anticoagulant or not. So these are the differentials we can think of. We should also search for the other parts of the body for the evidence of the bleeding manifestations, especially if it is due to DIC or senile purpura, maybe bleeding manifestation in the other parts of the body. And this patient should also examine properly, especially the fundus, to find out any fundal hemorrhage as a part of the routine examinations for the survey of the bleeding manifestations in different parts of the body. So this is the pictures of an elbow having the projections. It is very much become reddish. We are not understanding proper, cannot see the exact colors, but in contrast to his color of the body, it is very much hyperemic or reddish in color, and it was about to burst. And while I have tried to aspirate and the just chalky white color, so while I have found this chalky white color, I have become almost certain this is the chalky white, the crystal arthritis is there. So most likely the tophaceous, gouty tophi was there. So this is in case of chronic gout, and we have asked about the patient whether the patient has got the evidence of the previous arthritis or recurrent attack of arthritis, and we have surveyed the patients and was associated with the arthritis involving the other parts of the body also. And subsequently, the patient had been evaluated for hyperuricemia and also the renal functions, and the patient has been evaluated for other. The patient has got the excretion 24 hours urinary uric acid, because for the next plan of treatment, the patient definitely, as the patient has got the tophi, the patient should be submitted, should take the uric acid lowering drugs for the longer durations. And this should be whether the uricosuric drug should be used or uric acid suppressive drugs, the synthesis of the uric acid drugs which used for the inhibition of the synthesis of the uric acid. So this is determined by the looking at the 24-hour urinary uric acid. So questions may be what are the other manifestations can happen in these patients? What are the underlying conditions may be associated with this sorts of manifestations? What are the further investigations and management plan? So this is this gentleman very recently has presented to my chamber, was just with this cutaneous manifestations, just erythematous, patchy lesions and papular lesions. And just looking at this, what are the possibilities? Definitely localized cutaneous lesions, any, contact, what are the infiltrative lesions may rather we should think, or it is whether the patient has been submitted for the radiotherapy or not. This could happen with the radiation-induced erythematous lesions. So there are questions might be what are the other symptoms in these patients, or what are the other differentials we should think, or what are the differentials we should think in these patients. Differentials, again, I mentioned the cutaneous infiltrative lesions. Is it due to tuberculosis, or is it any fungal infections? or it is due to the infiltrative lesions like the tuberculosis or the sarcoidosis. Could be the differentials. Exactly. Subsequently, I have gone for the X-ray of these patients, and this is the picture just I have shown the involving the this cutaneous lesions involving the ala of the nose and the tip of the nose, lupus pernio. So a patient having lupus pernio, this is bilateral hyaline almost certain about the sarcoidosis. But the patients previously I have shown was exactly who was suffering from. When I have taken the history, who was diagnosed a few years back as a case of sarcoidosis and was treated in India as a case of sarcoidosis. Very recently, he has got the recurrence of these lesions. And finally, I have submitted these patients for histological examinations. Again, this patient has been the diagnosis come out of the non-KDH granulomatous lesion. So there is recurrence of the sarcoidosis in these patients. So next questions may be how are you going to treat these patients, or what are the investigations we'll perform to find out whether the disease is active or not. What are the investigations should be done in case of sarcoidosis before going for the treatment. So just look at the pictures. We are finding some, this is the colonoscopy findings. Some multiple ulcers in the pictures above, and the pictures below is some nodular or lesions over there. So it could be tuberculosis, it could be other ulcers maybe there. But in case of the patients has been excluded for the tuberculosis also. Actually, there is cobblestone appearance in the lower pictures below, and pictures above is usually in case of ulcerative colitis. But we should remember, any patients while suspecting the ulcerative colitis, before going for any interventions, the stools should be examined routinely to exclude the possibility of the amoebiasis. So this is another pictures. 45 years old male presented with the acute diarrhea. He gave a recent history of the use of the antibiotic, but could not mention the name. And endoscopy findings like this. So any patients having antibiotic and subsequently become diarrhea, so antibiotic induced or drug induced diarrhea, pseudomembranous colitis is a good possibility. So just looking at this picture, this is an endoscopy of, so these are the pictures of the, esophageal end of the stomach, and this is a sliding hernia. Just look at these pictures and involvement of the external, the auricle, the external ear is involved. He is badly diabetic. So while there is these lesions, maybe as a part of the vascular cause or sometimes the infective cause, we call the malignant otitis externa due to the pseudomonas. After getting treatment for longer durations of the antibiotic, he was badly diabetic. So this young man presented to us with sudden swelling of the, while there is localized swelling of any leaves, we should think about the possibilities of the allergic manifestations, angioedema. Of course, the other possibilities should be in mind, cheilitis and other things. But sudden appearance of the cheilitis, swelling of the leaves, goes in favor of the allergic manifestations or angioedema. So we should always should take the history, or we can be asked for what are the histories we should take. The onset is important, any precipitating factors, drugs or diet, or any other external factors may be precipitating these conditions. So next, what are the investigations we should go for? So this is not associated with the adult, in case of adult patients, this is a gentle, this boy was suffering from the sudden appearance of fever with few fine rashes and the typical strawberry tongue, and the patient was associated with the cardiac manifestation, chest pain was there, neutrophilic leukocytosis was there, and this was a case of Kawasaki. And early treatment with the aspirin and sometimes the immunoglobulin, IV immunoglobulin helps a lot in these sorts of patients. So we all know the causes of the macroglossia. We're not going the details. So just look at this gentleman is staring and looking, and with the features of the coarse appearance on the face, the skin become thin. And he has presented to me with these sorts of ulcers. And while I have examined the patients, the sensations of all modalities of sensations and reflexes was lost, all modalities of sensations were lost. So peripheral neuropathy with this sorts of this appearance, coarse appearance of the face, so rather leonine faces. So the diagnosis is overt, and probably it has been discussed in the previous lecture. One of my colleague, my honorable teacher, Mujibur Rahman sir, has discussed probably about leprosy. So this is nothing but leprosy, because the lepromatous leprosy, this is the typical appearance. And this is the involvements of the skin. So this is all about my presentations. Thank you. Thank you very much.
Thank you so much, sir, for this very interesting and informative presentation. Now it's time for the question and answer session. These are the questions you asked during the live session in the comment section. Now I would like to ask Dr. Ashim sir to start the question and answer session. Dr. Ashim sir.
Very much, Dr. Prince Kawser. We were just splendid, and we just almost looking with a splendid eye about the presentations. How many things we can learn from this short-term presentation. Thank you very much, sir, for a very big presentation, and this will be very much helpful for our trainees who are attending the session. Now we have a very few questions, I think, in the chat box. So the first question is, how to differentiate between the retinal artery occlusion from the retinal vein thrombosis clinically and by investigation?
Clinically, just looking at the, when the veins are occluded, we know there is retrograde, the venous drainage is impaired. So in the retina, there is engorgement of the veins, and also there is hemorrhages, engorged vein associated with the hemorrhages. And the hemorrhages with multiple dimensions, superficial hemorrhages involving almost the whole retina. So this is in case of retinal vein, retinal vein thrombosis. But in case of retinal artery, the circulation is totally occluded. So the appearance of the retina become pale, and sometimes the artery looks like the milky white appearance. So just looking at the fundus, we can say this is the arterial occlusions or the vein occlusion. This is one. And the investigations definitely, according to the history and examinations, will give us the clue. And to find out whether the artery or the vein is occluded, these are the picture. If we take the pictures of the retina, this could give a clue. Or to find out whether the artery is occluded, we can go for the MRV. And sometimes MR angiogram or any source of angiogram can help to get the locations of the arterial occlusions. But clinically, mostly we can say this is arterial or this is the venous. To find out the underlying cause, we can investigate the patients accordingly. Say a patient having, I have mentioned, a patient's elderly patients, no other finding, only having the history of unilateral headache, ESR is high. So most likely it is the giant cell arteritis. But a young lady having the recurrent history of the recurrent abortions, most likely, and having the arterial occlusion, most likely the SLE may be associated with the arterial occlusions. But in case of antiphospholipid antibody syndrome, mostly the venous thrombosis is there. So a patient's having severe headache, bilateral retinal vein thrombosis, or bilateral papilledema with hemorrhages, we should submit the patients for, the MRV. So then we can, the central venous thrombosis may be there. So accordingly, we should investigate it, underlying causes. Simple CBC may be helpful. Say a patient's having the retinal vein thrombosis, having the very high count of the WBC, spleen is very high, so most likely it is the CML. So it is the history and clinical examinations which will guide us to going for the subsequent investigations.
Thank you, sir. Sir, the next question is how we will differentiate between scleritis and episcleritis?
In case of scleritis, episcleritis is usually painful. In the movement of the eyes, it is becoming painful. But scleritis is usually not that much painful. This is the in gross differentiations. I think our chairpersons or Julhash sir may contribute in this aspect. Is there anything more than what I am saying?
Sir, there is another question, sir.
Yeah.
Hydroxychloroquine is frequently prescribed as DMRD. We all know that. Whether the maculopathy due to hydroxychloroquine is reversible or not, or in that case, what will be the treatment planning?
Yes, it is mostly reversible if it is detected early part of the disease, and just the discontinuation of the drug is enough. Discontinuations of the drug is enough, and we can, of course, sometimes sometimes the ophthalmologists, we can take the help of the ophthalmologists. Sometimes they go for the locally injections of certain steroids and other things. But I'm not very much oriented at the treatment of the maculopathy.
Sir, still now there is no more questions. So, sir, thank you very much for your excellent presentation, and it is very much helpful, sir, for all the trainings, and we are also benefited, sir. We have seen many new cases today and many new pictures today. This will help us to guide our students, sir. Thank you very much, sir.
Thank you.
With the permission, sir, with the permission of today's chairperson, now we move to the comments and remarks of our today's program chief guest, Professor Dr. Mohammad Julhash, sir, who is Professor and Head of the Department of Medicine of Marks Medical College. Sir, will you please give your remarks, please?
Sir, you have to unmute your mic first, sir. So your mic is not unmuted.
Dr. Prince Julhash, sir, is possibly in the mute mode.
Yes.
Sorry. Thank you. Thank you. Respected chairperson today, the Professor Nazmul Ahsan, the President Governor of American College of Physicians, Bangladesh chapter, and host Dr. Prince Kawser, and moderator Dr. Ashim Chakraborti, and learned viewers. Assalamu alaikum. It was really outstanding and extraordinary presentations given by our colleague, teacher, principal, and professor of medicine and head of the department of a government medical college. So I had been enjoying these presentations so keenly that I could not expect it should have been ended. So, and another thing, I should appreciate the speaker, how he could manage all these documentation, pictorials, and the patients, in spite of having so many busy professions in principal and professor of medicine, and how he could preserve all these things to present there to for the diversifications of the knowledge tools in medical educations. I really wonder, and I am really thankful to him, and really it was very good presentations. So in pictorial medicines, with these presentations, we definitely have come to the interpretation that the pictures or the Sochitra things are so important in the management, diagnosis and management of the diseases. So it is not now, it has been started earlier also. There are 25 to 30 years ago, it was started, the pictorial medicine. pictured medicine. So now in our country, by the courtesy of the CP and the Bangladesh Society of Medicine, they are being organized these health talk in different episodes. I must appreciate the SCP and the Bangladesh Society of Medicine also. Now, I cannot extend my speech further because the time is very short, and my evidence-based knowledge, that is diversifying tools, what I mentioned, the pictures, the history, clinical examinations, and the other investigations, and the pictures. So we cannot disregard anything. So everything should compose in medicine. That's why in medicine the theme is that we should catch a black cat in a dark room. So this is called medicine. This is called internal medicine. So I am proud of being especially in that subject. So now I should appreciate the present governor, and I should end my speech by giving thanks to the future governor elect for ACP Bangladesh chapter, the Professor Abul Kalam Azad. I congratulate him, and that's all my presentation. Thank you very much.
Thank you so much, sir. Sir, now I would like to request Professor Ashim Nazmul Hassan, sir, present governor of ACP Bangladesh chapters, to give his important comments regarding this presentation. Professor Ashim Nazmul Hassan, sir.
Assalamu alaikum. Good evening. Dr. Prince, am I audible?
Yes, sir. Yes, sir, you are.
At first, I must give thanks to Professor Miah for his wonderful presentation. We know he is a very good clinician and academician and also a leader. Through more than 30 pictures, he has discussed more than 60 diseases. So these pictures, these are tools and logistic through which we can diagnose a lot of patients. So main objective of our profession is to diagnose a patient and to treat a patient. How we diagnose these patients? We take a good history and we are to examine the patient thoroughly. So simple general examination, looking at the examination of the skin, we can get clue of many diseases. So if we miss these pictures, we miss these diseases, we will miss many diseases to diagnose, chance of diagnosing many diseases. So simply skin as a manifestation of many systemic diseases. This is very important. So this presentation, this program is organized on the objective is to help mainly the residents and early career physicians, particularly those who are preparing themselves for postgraduate examinations. So these pictures are sometimes given in examination in OSPI and also in other parts. So by seeing these pictures, we can diagnose many patients. Professor Julhash Uddin, he has said how he has collected so many pictures. I believe he has many hundreds pictures in his stock, and like many other physicians. He is academician, he loved to preserve these pictures. In our last session, Professor Mujibur Rahman, he also shown many pictures, and all these pictures are their collections. So during this COVID pandemic, this is an opportunity. We are taking this advantage Otherwise, these great physicians, they are engaged in their private practice for midnight. But during this COVID period, we are taking this advantage to see these pictures, their collections, and this is being disseminated to our postgraduate resident physicians. Two questions were asked. I want to Professor Titu, he has mentioned that episcleritis and scleritis, these are two important manifestations of rheumatoid arthritis. Sometimes before arthritis, some patients may present with these sorts of localized reddening of sclera, but when this is associated with pain, we can think that this is scleritis. So episcleritis is usually painless, but scleritis is very important clinical sign. So when there is scleritis, we must use steroid, and this is very important in case of managing in rheumatoid arthritis. Otherwise, sometimes a patient might lose the eyes. Another question also was asked, possibly, what is the management of hydroxychloroquine and chloroquine in rheumatoid arthritis. Sometimes this is a very important DMRD which is used in case of rheumatoid arthritis. But before starting these drugs, eye must be examined. But the patient may develop chloroquine deposition on the cornea, which is reversible. But once maculopathy develops and retinal involvement develops, it is mostly irreversible. That's why these patients are sometimes asked to examine the first after every 6 months, and 2 months holiday, that is after 10 months, these drugs are sometimes patients are asked to stop taking these drugs for at least 2 months a year. But every 6 months they have to examine the eyes, because corneal deposition, sometimes the patient may not complain of visual disturbance, but once maculopathy develops, there is irreversible damage to vision. So this is very important. So I am very much thankful to Professor Titu for his giving this time, for his excellent presentation. I am also thankful to Professor Julhash Uddin. He is also a renowned physician and clinician experienced clinician of our country, for giving this time. And Dr. Ashim for his wonderful coordination in this as a moderation in this platform. He is also Office Secretary of Bangladesh Society of Medicine. This program is organized by American College of Physicians Bangladesh chapter, but we arrange this supported in coordination with our parent organization, that is Bangladesh Society of Medicine. You will be happy to know that next program, there are two important programs are coming. One will be on 8th November. Professor M.A. Jalil Chaudhary, he is one of the renowned and senior most physicians of our country. He will be talk on acute medicine. This is emergency medicine. This is also very important. And on 10th November, at the same time, Professor Ridwanur Rahman, he will be talking on public health issues in medicine. So these are the very important topics. I think all young physicians or audience and listeners, they will invite and request you to listen to these topics. Again, I want to express thanks to Professor Mohammad Tumia for your wonderful presentation, for Professor Mohammad Julhash Uddin and Dr. Ashim Chakraborti for giving time. And finally, Dr. Prince Kawser, he is our young physician. He is our member in this team. He is acting as IT consultant of SCP Bangladesh chapter. With this, I want to conclude here and inviting you to listen to our next topics. Thank you very much.
We have come to the end of today's program.
We have come to the
As
end of today's
always,
program.
we have learned
As
so many
always,
important
we
things
have
from
learned
Sir
so
today.
many important things
Many
from Sir
thanks to
today.
the speaker, the
Many
chair,
thanks
the
to the
chief
speaker,
guest, and last
the
but not the
chair,
least,
the
the
chief
moderator
guest, and
sir
last
for
but not
managing
the
time
least, the
for
moderator
this
sir for
program from
managing
their
time
very busy
for this
schedule.
program from their
I'd like to
very
thank
busy
all the
schedule.
audience who were with
I'd like
us
to
throughout
thank
the
all
event,
the audience
especially
who
those
were
who
with
asked
us
very
throughout the
important
event,
questions.
especially those who
Hope
asked
you
very
got your
important
answers.
questions.
If
Hope
you
you
joined
got
late
your answers.
or couldn't
If you
see
joined
the
late
whole program
or
or missed any part
couldn't
of the
see
program,
the whole
there is
program
no
or
need to
missed
be
any
worried.
part of the
You
program,
will find the
there
whole
is no
program
need to be
on
worried.
YouTube right
You
after
will
the
find
live
the whole
session
program
finishes.
on YouTube right after
Our
the
Health
live
Talk
session
episode
finishes.
7 will held on
Our
8th
Health
of
Talk
December,
episode 7 will
where
held
Professor
on
Ame Jolil sir
8th
will
of
discuss
December,
on acute
where
medicine.
Professor Ame
It's a
Jolil
very
sir will
important
discuss
topic,
on
so
acute
don't miss
medicine.
it, guys.
It's a
See
very
you all in
important
the
topic.
next episode.
So don't
Until
miss it,
then,
guys.
take care and good
See you
night.
all in the next episode. Until then, take care and good night.